Hi guys, I'm Ricardo. I think I've met most of you already. I'm one of the PGY2s. I have an interesting case to share with you today. If you want to ask anything, feel free to jump in or just type your questions in the chat. I think I'll be able to read them. So let's get started. So the reason this patient came into the clinic is you're in an outpatient setting and the patient wants to establish care with a PCP. So he's a 33-year-old male who recently moved from Chicago, presenting to established care. He has previous medical history of HIV on antiretrovirals. We have a PCP's note stating that his viral load in February of 2022 was undetectable. And a stage 3 primary mediastinal large B-cell lymphoma, currently in remission. As part of his complaints, he mentions that he has noted neck swelling for the past 3 months. So I'm just going to share a little bit more of history before we start getting some questions. So 3 months before presentation, he got a COVID vaccine booster. He developed fever for 1 day. He noticed lymph nodes on the same side he got the vaccine, which was the right shoulder. Then, unfortunately, 1 month later, he developed COVID. The symptoms were mild and only lasted for about 4 days. He went to the ED and got an infusion with sotrovimab. His symptoms resolved completely. The only issue he continues to notice is a lump on his right neck. He called his oncologist at Chicago. He mentioned that most likely it was related to the vaccine or the COVID infection, so just to keep an eye on it for now. So now, passing this to you, is there any other details that you would like to know about this patient history or anything else that you'd like me to share about his prior medical history?
Ricardo, can you go back to the first slide for a second?
Sure.
Any fevers?
No, not today, and not now that he's presenting. He did get fevers after getting the booster and when he got COVID.
And at the time of the visit, how was the lymphadenopathy? Was he reporting that it's still present, or was that just that they received the booster that he noted that?
He mentioned it was still present. He wasn't sure. He thought it was a little bit bigger than when he noticed it initially. Overall, maybe unchanged, maybe a little bit bigger. And I see a question from Jonas. Recent weight loss, fever, night sweats. No weight loss, no night sweats, and fever only, as I mentioned, when he got the COVID booster and when he got COVID. Nothing since then.
What else do we know about his oncologic history?
Sure, I'm gonna skip to the next slide just so we can all see a little bit more. So he had a primary mediastinal large B-cell lymphoma. It was diagnosed in March of 2021. He underwent 6 cycles of Repuc. This is rituximab, etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin. He finished chemo in August of 2021, and then he got a PET scan around September where there was no evidence of disease. I'm going to add a little bit more about the rest of his history. He has HIV, apparently diagnosed around 10 years ago. Currently taking Descovy and TVK, and as I mentioned, we only know what the PCP note mentioned. We don't have exact values, but that's apparently he's undetectable. Surgeries, he had an incisional lymph node biopsy in February before the diagnosis, and he underwent placement of a port catheter in March of 2021. No known drug allergies. Regarding his social history, not sexually active for the past year. He denied any history of other sexually transmitted diseases. currently no tobacco, alcohol, or any type of illicit drug use. And there's really nothing significant for his family history.
Do you know how he presented the last time with his lymphoma?
So the first time he presented with the lymphoma, he also noticed some swelling on the neck. At that time, he did have some fever, night sweats, chills, and weight loss. He underwent imaging, and then he was found to have the lymphoma.
Thank you.
And where's the port catheter placed?
It's like anatomically wise.
Yeah.
Oh, yeah, it goes to the right axillary vein and then to the SVC.
Okay. And do you know when it was last taken care of?
The last time he underwent flushing and management of the catheter was about a month before presentation. He kind of lost a few appointments because of the whole changing providers situation. Okay, so I'll go over the review of systems. So as we mentioned, no weight loss, no fever, chills. Essentially, the only couple of things that were positive when you ask a little bit more detailed, he mentioned some dysphagia, neck swelling, some dyspnea while lying flat, and some occasional headaches that also he noticed when he was laying flat. Overall, the rest of the review of systems was negative. So before I jump into the image, is there anything you would like me to detail about any of the positives that we have?
How did he actually describe the dysphagia?
Sure. So he mentioned that dysphagia is like something feeling stuck behind his throat. It's the same for solids and sometimes with liquids. Once he feels the food passes down, there's no issue.
And all these symptoms, they started 2 months ago, and have they progressed, or has they noticed any changes? Were they even present then?
They weren't present 2 months ago. They have been starting to present for the past 4 to 6 weeks, and they have been slowly getting a little bit more noticeable.
No, he's referring that his neck is swollen. Is he referring to the one lump that he found, or how does he describe that?
Yeah, he feels the right side is a little bit more than the left side, but he has noticed that both sides of his neck is swollen.
Omar's asking if his extremities, if he's noticed that they're swollen as well, or they're swelling anywhere else.
So he didn't really notice that. He thinks maybe sometimes he feels a little bit puffy on the arms, but he hasn't really exactly noticed if his arms are swollen.
And with the swelling of the neck, is there associated, does he have pain or like any kind of tenderness when he touches it?
No pain.
And has when he touches his neck, is it pitting, slow swelling? Does it leave any marks? Or is it just that he's noticed that his neck is a little like bigger?
No, he hasn't noticed any marks when he presses on his neck. He only noticed the difference on the size.
You mentioned he doesn't have any dyspnea on exertion. How does it describe the dyspnea on lying flat? Is it just like at night, or?
Right, so anytime he tries to lay down, or if he goes to bed, he feels like something is pressing down his throat. So it kind of makes it a little bit more difficult to breathe in. So that's why he prefers to sleep with a couple of pillows.
So he does sleep with a couple of pillows. And did he ever mention that there's any noise, like out of sounds where he breathes, or?
Sorry, what was the question?
Did he mention that he hears any stridor or any wheezing?
No, no stridor, no weird noises when he breathes.
And Denise wants to know about his vision. Has he reported any blurry vision or any facial plethora?
No blurry vision. He doesn't really think his face has seen more of any different color compared to usual.
Gotcha.
So why don't we stop here for a sec before we move on to physical exam? And why don't we, let's have people say what are the main diagnoses that you guys have in mind based on the history alone.
Sure.
Anyone?
Go for it, Raj.
Recurrence of his lymphoma.
Okay, so recurrence of lymphoma. What makes you think that, Raj, just so that we don't all say sort of the same things? What makes you think that there might be a recurrence of the lymphoma? One thing that you noticed in his presentation.
Just like the physical presentation of a probable or possible mass in the neck.
Okay.
Yes, and what will go against that? I agree, we have to think of lymphoma.
Probably the lack of B symptoms.
He had them before and he doesn't have them now. So that will go against the idea that this is a lymphoma. But I agree that the first thing you would think is lymphoma, right? So Omar said SVC syndrome. So Omar, what makes you think of that? I fully agree.
Like the possible neck swelling that he's having, the headache that he's having when he's lying flat. Also the dysphagia, all of them might represent like a mechanical thing that's causing those symptoms.
That there seems to be some obstruction that could involve, his airway, and it could involve his SVC. So that, and if it were an obstruction, what would you think of as what's causing it?
Okay, it can be like possible like tumor, the tumor itself, recurrence of the tumor, the lymphoma.
Okay, so some intestinal, widening with compression of the SVC. He also has a portal a catheter, right? So, that sometimes can get thrombosed and patients may present, right, with SVC syndrome. And it's important to ask about, if he's been taking care of it or not. Okay, I think those would be really the main things that come to mind. Of course, the differential is wider, but let's wait until we get more information from the physical exam and labs before we start including other things.
Okay, so let's see. So this picture, this is unfortunately not the patient, but I found this picture that is pretty similar to how the patient presented. The only difference that I will add here is, let's see if I can use the pointer, is when we saw the patient and asked him to remove his mask, we could see the outlines of the mask right like on top of the nose, all over the face. And the rest of the physical exam was pretty similar. So now taking that, you just ask the patient to remove his shirt. Based on that, what else would you like to know about his physical exams? And is there any maneuvers or findings that you would like to try to get from this patient? I'm gonna go back to the picture.
Raise his hands beside both of his heads.
What is that called, Daya?
Is that Pemberton sign?
And where else? In what kind of condition can you see that? Or what does it represent? You don't have to remember that, but why
Presents
does that happen?
Cava syndrome. You can see the thoracic outlet syndrome as well. And you can see it something similar in people with thyroid disorders.
A bit enlarged thyroid. Something's obstructing the thoracic inlet. Okay. And then he's just saying that the maneuver that you just described.
Great. Yeah.
What other things, and maybe Raj, you were thinking of chylothorax and
There's like I think there's something going on with his lymphatics, but with the shortness of breath, something kind of causing a compression on the lungs.
so do a chest examination, and what will you find then?
I don't know what you'd find with a chylothorax, to be honest.
Well, think about what it represents, right? Like what's going on in the chylothorax?
You're gonna have lymphatic fluids building up outside of the lymphatic system. So the shortness of breath that he has could support that, especially when it's positional. But you'd also probably have chest pain. I'd ask if he has pleuritic chest pain during a physical exam as well. It probably cause some inflammation, but not too sure what else.
And with like pleural effusions, you would have like decreased red sounds and like dullness.
Right.
And other things that you guys want to know about his physical examination. I think it looks pretty abnormal. Anything else? The thorax or any other, you like to look at his neck veins, his legs, anything to expand. Christina's asking about stridor. You would check the, yeah.
Great question. No, we didn't hear any stridor when we were examining him.
So Ricardo, I know that in this photograph, this patient probably was wearing some dirt exposed to the sun, but does the edema follow that pattern as well, like a V-neck edema?
It was more, yeah, it was more on bilateral shoulders, upper extremities, and neck up. So it wasn't too much neck down, but yeah, it was a very similar presentation.
Thank you.
Do you want to show us what else you found in his physical exam? Ricardo?
Okay, so something very important are the vital signs. His blood pressure was 114/72, heart rate 96, respiratory rate 17. No fever, saturating 100% on room air. And a few positives. We saw the face mask, noticeable on his face. There's bilateral jugular distension and some soft tissue swelling. We also noticed right anterior cervical lymphadenopathy. It was about 2 centimeters, mobile, non-tender, no erythema. The chest and lungs, as you saw, dilated collateral veins on the right chest wall and shoulder. The port entry on the right thorax didn't have any signs of or symptoms of infection. It was completely normal. And extremities, there was trace non-pitting bilateral upper extremity edema to the, sorry, that was actually up to the shoulders, neck and facial swelling. The rest of the physical exam was pretty unremarkable. So who wants to give the problem representation a shot?
Omar, take it away.
So the patient is 33 years old, male with history of well-controlled HIV and B-cell lymphoma that was in remission, presenting with dysphagia and a recent worsening of his neck swelling after getting a booster shot with no other B symptoms. His exam was remarkable for dilated neck and chest veins with facial swelling.
Excellent. Just remember, age groups, right?
Yeah, like a middle-aged male with like I'd say subacute to chronic presentation.
Omar, they're only 33, young.
Yeah.
Really young, Omar.
Ricardo, share yours with us, please.
So you nailed it. I think you did a better job than I did. So a young male with previous medical history of well-controlled HIV and a primary mediastinal lymphoma, currently no evidence of disease, presenting with upper dyspnea and dysphagia, found to have facial and upper extremity edema, neck swelling, jugular distension, right cervical lymphadenopathy. So now, based on what we know so far, and now that you have the patient in front of you, what do you want to do? You're in the clinic, you're in the Ryan Center, it's 4:30 and you're about to close the clinic, it's the last patient you're seeing. So we have a poll. Which choice would you like to do?
All right, 10 more seconds. Or not. There we go.
Great. Okay, I'm glad everyone chose sending him to the ED. So now that we decided that we're going to send him to the ED, and we can use the chat for this, you can just type in the letter that you think, which would be your working diagnosis, that you would call the ED team and let them know, hey, I'm sending this patient, I suspect this. And try not to choose F. You can use that as a last resort, but just try not to choose it.
Okay. About to end the call. Final whole thing.
Okay, so everybody 100% chose vascular obstruction. And we're going to discuss a little bit more about that a little bit later. There's quite a few home run type of clinical signs that we're seeing in this patient, but there are a few differentials to take into consideration. And I wrote this list mostly based on what we know so far. And yes, definitely superior vena cava syndrome is the top of our list as differentials goes, but we have a few causes that can be the etiology of it. One, it can be the lymphoma. We know he has a primary mediastinal lymphoma history, so there's always a chance that the relapse is in the same area. But as Dr. Pergolini mentioned, and it's quite a very important point, is that every patient, and now with every patient getting a port catheter or any type of thick line or central line, there's always the risk that there's thrombosis of any of the central lines. And there has been a rise in superior vena cava syndrome secondary to thrombosis of the central lines. I also added pericardial effusion as the second option, and the reason why is there can be a clinical presentation that is chronic or at least subacute, and it can have very similar symptoms to an SVC syndrome. Management-wise, it would be completely different, but etiology-wise, it can have very similar causes. So it's something that we need to take into consideration. The physical exam will give us a lot of information to choose one over the other, but it's something always to keep in mind. Just to keep the mind open in a broad list, CHF, pulmonary hypertension, even though we only see upper extremity signs, no lower extremity signs is something that, and PE are both diagnoses that we need to take into consideration. This patient didn't really have history of hypothyroidism or goiter, but we mentioned that intrathoracic goiter can also cause SVC. Few weird things to consider: medication side effects. This patient has already received four chemotherapeutic agents. We know he was a little bit out of the window of chemo, but some of the side effects, for example, of fetopulside and doxorubicin, can be related to facial edema. It's also something to take into consideration. Okay, so you're gonna send the patient. We already have a working diagnosis. Is there anything specific, either labs or imaging, that you would like to let the ED team know that they should get, or that you think they should get?
All right, guys, what do we need? You send the person to the ED. Okay. So we're getting imaging, we're getting labs. Now, what makes the CBC with differential your first choice? What are you looking at?
We're worried about recurrence of lymphoma, so we can see what the white cell count looks like.
Okay, cool. That makes sense. And at the same time, we're getting imaging, and I see a CT chest of the neck with contrast, and I see a an ultrasound at the right upper extremity. Okay, to see if there's any, Lenise, is that to see if there's any obstruction there?
Is there any preference, or would anyone prefer maybe CT versus Doppler? Is there any advantage to getting a CT over a Doppler?
Omar seems pretty determined. The CT is what he needs. Because you're assessing for the possibility of the obstruction being a tumor. And the CT will give you more information. Okay.
Doppler is cheaper. Okay, I like that answer.
That is if you can get it in the ED.
But there's also something to take into consideration with ultrasound. Well, Doppler is hard to get sometimes in the hospital. And if you do get a CT with IV contrast, you can also rule out thrombosis. So you can kind of assess both things at the same time with the CT over the Doppler.
Ricardo, what should we get though? Like once our patient goes to the ED, and if it's your first evaluation.
So the first thing I would get, to be honest, other than the vital signs, I think just a focus or a quick assessment with ultrasound of the heart, just to make sure, I'll mention that again, but just to make sure there's no effusion. And after that, the next best thing to get is a CT of the chest and the neck with IV contrast. The rest of the tests we should get, we already mentioned, we think this patient has a lymphoma, possibly a recurrence of the malignancy. So we need to check a CBC, electrolytes. We need to make sure the renal function is fine. Any patient with lymphoma, especially if we suspect a bulky disease, is at risk of TLS. So we should also get LDH, uric acid, phosphorus as part of the baseline testing. Other than that, there's nothing really urgent that I think we should get in our patients, in this patient. So now that let me mention that, these are some of the initial labs. So the CBC, grossly unremarkable, hemoglobin of 13.5. We don't know a baseline, and overall coags are normal. Liver function tests are much within normal limits. Same with the BMP. Uric acid is 4.9, LDH is 873, so it's elevated. They get a few other studies, but I just added this right away to make sure that you knew about them. He was undetectable for HIV, and he had a CD4 count of 342.
So just to clarify, this is not something that was done in the ED, that you just would send these tests right away? Okay.
No, I wouldn't really be too worried about hepatitis or any viral tests. When I get this patient, eventually we need to check for all of these factors as part of the lymphoma workup, is making sure there's no viral infection, check EBV, CMV, etc. We know this patient is HIV positive, so we need to know about his baseline status, but all of that comes later. So it's not something we need to do when the patient is just presenting.
Right, later, and if you don't have the information available, I presume. Okay.
Right. So I'm going to show you a little bit some imaging. I'm not great with CT scan, but I found this really useful. If you don't follow the radiologist page in Instagram, I highly recommend it. It's really useful, and it goes step by step if you need some help with imaging like I do. So I tried to find the image at around the same area. So to locate ourselves and try to make it a little bit easier, we have the bronchi here. We have the pulmonary trunk and the bifurcation and the ascending aorta. So this huge ball here is a mediastinal mass. And if you see the SVC on the right side, which would be a normal patient, it would have a fairly big size compared to the SVC that we see on the patient's CAT scan. So with that in mind, I wanted to show you a video of the CAT scan. And starting from around the same point that we mentioned. So you can see everything that the anatomy is very distorted because the mass is very big. Let's see. You can even see a little bit of compression of the esophagus, some movement of the trachea. It's not necessarily compressed. And here in the end, you see multiple additional vessels. All of these are pretty much collaterals that form with the chronic obstruction of the SVC. And that is part of the findings that we saw in the patient when he removed his shirt. Okay. And I just wanted to show a few more slides of imaging, especially on this side. You see this transversal cut. You see quite the significant size of the anterior mediastinal mass with significant compression and displacement of a few structures. And I did this sagittal plane mostly because when I'm gonna show the final read of the CT scan in the end, but this this shadow that we see on the right IJ was not mentioned at all. This is most likely a thrombus. And this is another shot of the mass, a little bit more on this place to the right, closer to the SVC area. On the transversal cut, we also see quite the narrowing of the lumen of the vessel, which is a severe obstruction of the SVC. So the CT scan was read as a severe compression of the SVC secondary to this anterior mediastinal mass. They mentioned it was about 8 by 6 by 5 centimeters. And the CT of the neck only mentioned this occlusion of the right IJ. They mentioned it appeared to be encased by the mediastinal mass, but vascular surgery was consulted and they thought this was a thrombus, so it was treated as a thrombosis of the right IJ. Okay, so that was everything initial about the case. I will go over the hospital course a little bit later in the lecture. Is there any questions so far before we kind of change the discussion a little bit?
No, but I did want to say, because we are unfortunately a little limited on time, and we did discuss part of the oncologic emergencies in one of the lectures before. Okay.
All right. So I'm going to talk just about a couple of oncologic emergencies. What I want you to get out of my lecture is why it would be an emergency, what initial measures you should take, and what specialists you should bring into the team as part of the multidisciplinary team to manage these patients. Essentially, we can divide them by either structural, metabolic, hematologic, or treatment related. Based on that, we have a few different types of emergencies. Structural, we have SVC, spinal cord compression, and pericardial effusion. Metabolic, TLS, hypercalcemia, some authors consider SIDH as part of the oncologic emergencies. Febrile neutropenia, hyperviscosity, and hyperleukocytosis. And now, especially now that we have so many immunotherapy-related medications, we have a lot of immunotherapy-related side effects that we also need to take into consideration. TLS can be considered as both treatment or hematologic related. So starting with superior vena cava syndrome, which is the condition our patient had, is pretty much any condition that can lead to obstruction of the blood flow through the SVC. So it can either be malignant or non-malignant. Initially, it used to be more non-malignant causes used to be much more common, especially infectious causes like syphilis, TB. But as antibiotics have gotten better and we're getting a little bit better on treating infections, malignant causes have been the most important etiology. About 80% of SVC cases. As you saw, it's a clinical diagnosis. So you don't really need the imaging to say a patient has superior vena cava syndrome. We have a constellation of symptoms that could lead to the diagnosis. And it's an emergency because it can lead to life-threatening airway edema or cerebral edema leading to brainstem herniation. So either one of those are fatal. It's not the majority of patients who will develop these complications, but it's something that's possible. So we need to intervene as soon as possible. Regarding frequency, the malignant causes are essentially lung cancer. So the big majority of SVC will be related to either non-small cell or small cell lung cancers. The rest is non-Hodgkin lymphoma, which would be 10 to 50%. And then we have a few others like thymoma, primary germ cell tumor of the mediastinum that can also cause SVC syndrome. This great pictures I got from the New England Journal of Medicine. Essentially, you will see a big tumor, especially tumors that grow on the right hemithorax. And that's why lung cancer and non-small cell lung cancer usually is more related to this type of pathology. They will obstruct the SVC outflow, inflow to the heart, and that will cause edema literally distributed all over the upper body, which is the venous drainage of the SVC. This to the right is called the Stanford Classification, and it's a classification of the severity of the obstruction and the outflow that we have. Usually there's collateral circulation that can bypass the SVC return to the heart. So that takes both things into consideration. It goes from A to D. Patients who have C to D, classification C to D, usually have a higher risk of complications like airway edema and cerebral edema. So some clues about patient who has SVC syndrome is the prior oncologic history. We had a good red flag with our patient. He already had a primary mediastinal malignancy, so that raises the flag that this is most likely an SVC syndrome. But if the patient doesn't have an oncologic history, we can think about the age and smoking history. We know patients over 50 years old and who have significant smoking history are at a higher risk of lung cancers. And as we said earlier, IV devices can lead to thrombosis of the SVC and obstruction. Pacemakers with leads that go through the SVC also should be considered as part of the of something that can be thrombosed as a medical device. And it's usually subacute. It has a subacute to chronic presentation. Most patients will have the same presentation as our patient, with facial and upper extremity swelling, head fullness that can be worse by bending forward or lying down. And this list of symptoms is from more common to less common. So the more common is distended chest, neck, and neck veins, visual symptoms, dyspnea, cough, and hoarseness. They go down to facial plethora, syncope. And the differential, we mentioned a little bit about it. Just patients who had radiotherapy in the past, we should consider. Some patients with Cushing can seem to have a little bit of a similar facies, but most of the rest of the presentation will not be similar. And the diagnosis is clinical, but the best imaging tool that we have is the CT scan with IV contrast to help us determine the presence of thrombi and the degree of the obstruction. So this is a picture of a patient who has all of the classical symptoms of SVC. And the initial approach and the main thing you need to do when a patient with SVC is see if the patient has life-threatening symptoms or not. What are those symptoms is any decreased level of consciousness, confusion, or altered mental status that can be a sign of cerebral edema. You can also consider blurry vision and visual symptoms as likely impeding papilledema. So it's something you take into consideration. Stridor, hemodynamic instability. So all of these mean that there's an impeding either respiratory arrest or brainstem herniation. So the main thing is usual ABCDs, security airway, make sure that the patient has an adequate preload. And these patients will need to have a more rapid intervention, most likely stent or thrombectomy. Just remember that these patients, we're talking about likely laryngeal edema, so this will be considered a high-risk airway and a difficult airway. So you will need quite a big team involving anesthesia, critical care, vascular, and CT surgery. If they don't have any life-threatening symptoms, then the best next step is to get further imaging, try to characterize what's causing the obstruction. If it's a malignancy, try to get tissue diagnosis, and the treatment depends on what the diagnosis is. And depends on the malignancy. We're not going to go into detail on any of those, but there are a few general measures. Nothing of this is strongly evidence-based. There's not enough cases to do randomized controlled trials, but simple measures like keeping the head of the bed elevated to improve vascular drainage to the right heart. And steroids have been discussed. It's not strongly recommended at this time. It depends a lot on the malignancy. Now, regarding a few technical issues, the IV access might be unreliable if it's placed on the upper extremities, since all of the medications will be going through the brachial to the axillary vein in any side. There's a chance that medications might take longer or might be ineffective when they're given the upper extremities. And as I mentioned, the intubation. And the treatment is based on the primary etiology. Some temporizing measures like an endovascular stent or thrombectomy might be needed. This picture is of a patient who has severe SVC and underwent a stent placement. So now you see that the dilated proximal vessels are not noticeable compared to the right side. I think we're almost running out of time, so I'll do this one quickly. You have a 48-year-old male with previous medical history of alcohol, tobacco use disorder. He presents to the ED with progressive dyspnea over the past 2 months. And on the physical exam, you see distension of the jugular veins and enlarged left cervical lymph node. This is the chest X-ray. And I think we have a poll for this one. What would be the most likely diagnosis?
Do you have the options for the question?
Oh, I thought we had a poll. No,
Huh?
never mind. No, I thought we had a poll, but I don't have the answers here, but any brave soul has a guess?
Does
Yes,
anyone
just-
see anything? Huh?
You can just tell them.
Or
Yeah,
maybe
so-
tell us what we're seeing in the X-ray first, and
So the main thing to notice is, and well, I'm going to mention this, but the mediastinum itself is wider than it should be. We do see the aortic knob here, but the heart is enlarged. So based on that, this is actually a case report from the New England Journal of Medicine. This is a malignant pericardial effusion. And that happens in around 20% of cancer patients. And it's also very common in patients with lung cancer. It has multiple possible etiologies, but the important part that I wanted to bring up is that it can have either an acute presentation with a pericardial tamponade, as everybody knows, the Vena triad, but it can also have a subacute or chronic presentation like this case. And it would present very similarly to a patient with SVC syndrome. So sometimes the chest X-ray can help differentiate. Now that we have access to ultrasound, it's very easy to take a quick look at the heart, make sure there's not infusion, and then proceed to the CT scan. That's also just something that just wanted to bring up. And presentation of a malignant pericardial effusion is similar to a normal pericardial effusion, just with a patient with cancer, or that it's rare for a patient to present initially with pericardial effusion, but if that's the initial presentation, lung cancer and breast cancer are the most common causes. And the management is, the main thing to do is drain the fluid. It doesn't really matter if the patient is stable or not. The priority is to remove that fluid and then just prevent reaccumulation with a catheter or surgical treatment. So the first teams that we should involve are CT surgery, oncology, and healthcare. This is a very poor prognostic factor that most patients have a very low 1-year survival after this. I know it's late, so I'm gonna skip the spinal cord compression, I guess, because I know that Rafa gave you a very, very good lecture about this. So I'm not gonna add anything else. I know he did a great job with that. And same with TLS. The only one I do want to talk a little bit, and it's just a few quick words, is hypercalcemia. It can be relatively common in 10 to 30% of cancer patients. The most common ones, and this is pretty much a trend with any of the oncologic emergencies, is breast, lung, and non-Hodgkin lymphoma. But multiple myeloma is also important for hypercalcemia, and the etiology is usually humoral. Lytic bone lesions are not as common as humoral, either PTH-RT or exogenous production of activated vitamin D. And it's an emergency. If the levels get above 15, there's a high risk of coma and cardiac arrest. As any of the other emergencies, it has a very poor prognosis. The signs are very non-specific, so patients can only present with anorexia, nausea, vomiting, constipation, some malaise, and when you start to see polyuria, polydipsia, usually calcium levels are a little bit higher. And the high-risk patients are downstream lethargy, confusion, and coma. So this is a brief summary of what to do with hypercalcemia. Always remember that you need to correct the calcium for the albumin level, especially in cancer patients who you know might be malnourished. And part of the workup should include CBC, renal function, magnesium, vitamin D, and phosphorus. So mild hypercalcemia is anywhere from 10.5 to 12, and patients who don't have any symptoms. You don't really need to be aggressive or do an immediate treatment. Patients can even be treated as an outpatient with adequate hydration. 6 to 8 glasses of water a day are recommended, and avoid any medication that can increase the vitamin D levels. Regarding the diet, they recommend a diet under 1 gram of calcium daily. I don't think a lot of people actually get to the gram, but it's just something to know and try to assess when you have one of these patients. A patient with moderate hypercalcemia from 12 to 14 can have mild symptoms. And you can consider outpatient management based on, of course, the patient and how reliable the follow-up will be and how much access to care they have. And usually you can just do the same general measures as a mild hypercalcemia, and just take into consideration those patients who need close follow-up to make sure they don't go into the severe category, which is any patient with calcium above 14. Now, most patients will be completely symptomatic at that time. So the main thing, fluids, calcitonin, and bisphosphonates. The fluids and the calcitonin are the immediate treatment that will act in the first 24 to 48 hours. And the bisphosphonates start to act 48 hours later. So it's pretty much a bridge from one to the other. I know some patients will be difficult to manage. We always have CHF and CKD patients. So it's a good idea to involve nephrology, especially if you're considering diuretics. And endocrinology is always a good team to involve also with these patients. So a brief hospital course of the patient just to wrap this up and let you guys go. The patient was seen by vascular cardiothoracic surgery and oncology. Overall, nobody needed to do an acute intervention. He was just started on anticoagulation for the right IgA thrombus. Since the most likely cause was the lymphoma, they did a biopsy of the cervical lymph node, which was really easy to access. And he underwent steroids that were started 4 days after the biopsy. This is like very responsive malignancy. And the lymph node showed a diffuse large B-cell lymphoma. So he was started on RISE, which is another type of chemotherapy 5 days after the biopsy. He had a few complications during his whole course, but overall he had some febrile neutropenia, he resolved, and then he was discharged. And he's on a clinical trial, a very specific one, which is very fancy. And I wanted to show you, this is the last imaging that he has. The left side is the new image and the right side was the initial image. The difference is there's no IV contrast on the left, but this is the size of the mass now compared to then. So this is not a great way to compare, but overall it seems like the compression of the structures is not as bad as it was. And the size went down by about 4 centimeters, so maybe half of the initial size. And those are some of my references. Wait, I think we just finished. Okay. And that was it.
Thank you, Ricardo. That was a great presentation. I would be curious to know, how often you have this, the lack of B symptoms with recurrence of the same lymphoma. So I don't know, to me, that's something that's worth looking into. Because in my mind, it's not common, and if it's not, you might be able to publish it, right?
So I think what we discussed about this patient is I saw him in February, so he was just maybe less than half a year out of treatment, and to be honest, we already knew he was relapsing because we were seeing him for a relapse, but I think it was so early in the course that we already had imaging. We already knew that he was having the relapse, so he didn't have the time to develop these symptoms yet.
I'm not sure if I will agree with that. I mean, he already had SVC syndrome. So, it had been growing for a while. I don't know for how long, I don't know how fast it grows, but I mean, it was an advanced presentation.
Yeah, it was really, really weird because the last PET scan from September didn't really show anything. And then by February, he already had this big mass. And that was the confusing part. Because he did have very close follow-up with the oncologist as an outpatient, but it was really strange how quickly it grew.
Okay.
It has
So let me just point something out to the audience about something that I think Ricardo did very, very well, which is, he chose his patient, and then when he put together a presentation, he included these questions. But what would you do if you're at Ryan, right? Would you do workup? Would you send, he chose what his main teaching points were, which is, SVC syndrome is an emergency, which, it seems that everyone was very well aware of that, and that's fantastic. But I'm just pointing out that Ricardo did an excellent job not only at presenting the case, but also at choosing how to present it and making it educational when you choose what your teaching points will be. And then, if anything, you were a little bit, I think, ambitious in trying to cover all oncologic emergencies. But that was great. And I think, the patient who presented is very, I think it's going to stick in our minds in terms of, how it typically presents and what we should do if we see anything like that. So thank you. That was a very good presentation.
Thank you.
Thank you again, Ricardo. Enjoy the rest of your afternoon, everyone.
I would completely agree. Great presentation. Did you actually see him at the Ryan?
No, I was at the BMT clinic.
I was so excited that it could have been someone walking into the Ryan. But, okay.
No, it would have been great, but no, unfortunately no.
But you would have done the same thing. I know that. So.
All right, bye, everyone.